Hello everyone, I am Dr. Sandeep Sharma and I welcome you all to this MCQ discussion session. I will be discussing 10 MCQs in pediatrics which are based upon the latest NEET super speciality as well as the IRI super speciality pattern. The point is not to teach you anything new but discuss certain MCQs which encompass certain concepts, and these MCQs have been taken from all the specialties of pediatrics and they relate to something important in each area. So let us begin the discussion. First of all, let's start with general pediatrics and start with malnutrition, because being a pediatrician, malnutrition is something which just does not leave you at any point. So question number 1, which among the following is the initial fluid of choice in a kwashiorkor child who develops severe dehydration with shock? If you look at the recent papers of NEET super speciality, you will find that there is a pattern. They will always have 1 or 2 questions based upon what is the particular fluid of choice in a particular common pediatric condition. So whatever common pediatric conditions are and what are the corresponding fluids, you need to remember that. In general, you need to know that whenever there is a patient with shock, we go in for IV fluids, and normally ringer lactate or normal saline are the preferred fluids. But the situation slightly changes when it is a kwashiorkor or marasmic child. So basically what we have here is, we have a kwashiorkor child. So we have a severely acute malnourished child who is having severe dehydration with shock. That is important. So SAM child, how you are going to manage fluid management in a child with dehydration? That is what the question is going to talk about. Let us not look at the options. Try to understand what are the things that you need to know, and then we will look at the answer. So whenever you have a child with severe acute malnutrition, either kwashiorkor or marasmus coming to you, in a SAM child, the hydration status is sometimes difficult to assess. So any child with watery diarrhea, we assume that the child is having at least some dehydration. At least some dehydration is there in that child, right? And in case the child is having any features of shock in SAM child, you will say the child is having severe dehydration with shock. So this is what the clinical initial assessment is. Now, how you are going to manage these children? When it comes to management of these children, the acute management first of all will depend upon what is the category of the child. So you can have first scenario where the SAM child is having some or severe dehydration, but there is no shock. Normally, whenever there is some dehydration in a normal child, we give ORS to the child, and whenever there is severe dehydration, we use IV fluid, right? But in case of severe acute malnutrition, whether it is some dehydration or severe dehydration, provided there is no shock in the patient, you will use only and only oral fluids. You will avoid using IV fluids in these patients. This is the first concept that you need to understand. So in some or severe dehydration, what will be the fluid of choice? The fluid of choice in these patients will be Resomal, rehydration solution for malnutrition. Now the problem is Resomal is not commercially available. So how you are going to use it? You are going to prepare it yourself. So what we do is, we take the normal WHO ORS. Normal WHO ORS packet is to be diluted in 1 liter of water. We will dilute it in double the amount, that is, you will add it to 2 liters of water, plus you will add 50 grams of sucrose, and you will add 40 ml of mineral mix solution. If mineral mix is not available, as is the scenario in certain resource limited settings, you can substitute it with 45 ml of KCl. One out of these two, either mineral mix or 45 ml KCl, right? That is, once you prepare it, that is your Resomal solution which has been prepared. So how you are going to use Resomal? You are going to give it either orally. If the child cannot accept orally, you will give it through nasogastric tube. And what is the amount you will give? What is the regime? The regime is very simple. The regime is 5 to 10 ml per kg per hour, either orally or nasogastric tube, which will be given for 12 hours. This will be the amount of Resomal you will give for rehydration in the child. You will correct this dehydration over 12 hours. And for ongoing losses, you will give 5 to 10 ml per kg per loose stool. Simultaneously, breastfeed is allowed in the child, and once the child looks hydrated, which is about 2 to 3 hours after you have started rehydration, you can also consider F75 feed in the child, right? So this is the first management, first point, some or severe dehydration with no shock. Now the second scenario is the one which has been given to us in the MCQ. The second scenario is there is severe dehydration with shock in a SAM child. In these patients, we will use only and only IV fluids. IV fluids are to be used. So the question arises, what is the best IV fluid? The best IV fluid is Ringer's lactate in 5% dextrose. That is the best fluid. But this is not easily available at all places. And so alternative fluids which are available, you can use either N/2 5% dextrose, half normal saline in 5% dextrose, or you can use Ringer lactate alone. Right? Pure dextrose containing solution are not to be used. Normal saline again is not to be used. Now, what is the regime that we follow here? The regime is very clear. Initially, all children, you will give a 15 ml per kg IV bolus of this fluid over 1 hour. After giving this fluid, you will assess the child. Right? If the child improves, and second scenario will be there is no improvement. In case there is no improvement, after 15 ml per kg bolus over 1 hour, you will treat it as septic shock. So the child will go into the septic shock algorithm. So you will treat as septic shock in the child. And you will also consider early inotropic agents in this child. You will also give IV antibiotics in this child. In case the child starts improving, you will repeat a bolus. That is, you will give another 15 ml per kg IV bolus over 1 hour. And then you will, only 2 boluses should be given IV. Then you will shift to oral or NG feeding. What you will give here? You will give Resomal solution in a same dose that we discussed. 5 to 10 ml per kg per hour, which will be given for about 10 to 12 hours. Right? So this is the management of severe dehydration with shock in SAM child. What I have discussed is an area many residents and many of you tend to ignore. It is a very, very important thing, a scenario-based thing, one-liner thing, anything can be asked in your super specialty entrance exam. Let us have a look at the question again. Which is the initial fluid of choice in a kwashiorkor child with severe dehydration with shock? Obviously, it will be Ringer's lactate with 5% dextrose. C is your answer. Let us move to the next question. Light bulb sign on MRI suggestive of which malignancy? MRI, ultrasound and chest X-ray, named signs are very frequently asked. In NEET super specialty, you will find at least 2 to 3 questions where they are mentioning about the name, a particular named sign of a particular disease. Light bulb sign on MRI is classically seen in patients of adrenal pheochromocytoma, and that is your answer. Answer to question number 2 is A. Point of me taking this discussion is not only to discuss important points and MCQs, but also to tell you that when you are preparing, there are certain areas, certain ways questions are asked. So when you are revising, you should be focusing on those specific areas as well. So what is the light bulb sign? When you do abdominal MRI in patient with adrenal pheochromocytoma, you will find a sign like this. Look at this green colored structure. There will be T2 hyperintense mass suggestive of adrenal pheochromocytoma. However, you need to understand that this is not diagnostic and there can be false positive, false negative cases also. There can be adrenal pheochromocytomas which may not be that intense. However, the classic light bulb sign has been described in these patients. Usually, adrenal pheochromocytomas in younger population tend to show light bulb sign a bit more commonly. However, again, this is a disputed area of at your level, just need to remember where the condition is seen. And if you get a photograph like this, how to identify. So, answer to question number 2 is adrenal pheochromocytoma. Question number 3. 5-year-old child developed AKI, that is acute kidney injury with acute tubular necrosis. The child was advised fluid restriction. You know that whenever there is pre-renal type of AKI, you give boluses. But wherever, if the child is having intrinsic renal AKI, established AKI due to acute tubular necrosis, there are chances of pulmonary edema, volume overload, and so you do fluid restriction. So child was given fluid restriction as per protocol and he was monitored daily. So it was fine till so far. Day 3 of admission, he was found to have a weight loss of 3% in 24 hours. And his corresponding serum sodium was found to shoot to 149. Normal sodium is 135 to 145. So what is happening here? During monitoring, his weight has suddenly fallen and his serum sodium has suddenly jumped. What it means is he's receiving less fluids. So which among the following is the likely reason? Before we discuss and come to the answer, there are a few points that you need to understand. Whenever a child is started on fluid restriction in AKI, how do you do it? Whenever there is in ATN, acute tubular necrosis causing acute kidney injury, you replenish only losses which are happening. You don't give any maintenance fluid. So you replace urine output in the child, plus you replace insensible losses. Usually insensible losses are in the range of 400 ml per meter square body surface area. Plus you will replace any extra renal losses, volume for volume. For example, if the vomiting has happened, so if child has vomited 15 ml, you will replace it with 15 ml. This is what the fluid restriction is. And whenever you are doing fluid restriction, you need to monitor two things on a daily basis. Obviously you will do your input, output and everything, but daily weight gain monitoring as well as daily serum sodium levels are mandatory. So there can be two scenarios. And daily what should happen? There should be in a child with fluid restriction, there should be 0.5 to 1% of daily weight loss. This weight loss is actually not due to actual fluid loss happening, but it is mainly related to the caloric deprivation. But the daily weight loss should be in the range of 0.5 to 1%, and the serum sodium should be within normal limits. That is, it should be between 135 to 145 milliculoids per liter. Any deviation needs to be corrected. Now, there will be two scenarios you can get in the MCQ exam. You can also get in your practical life as a pediatrician. First scenario, if there is daily weight loss more than 1% with rise in serum sodium as it has happened in this child, you should suspect that there is overzealous fluid restriction. You have restricted more fluid than it was needed, and so there is inadequate fluids are being given. There is hemoconcentration which is happening, and so the serum sodium has risen in this child. What you will do? You will give fluid replacement in the child. And if there is no weight loss or paradoxical weight gain with low serum sodium, then fluid restriction is not effective. You need to do fluid restriction more efficiently. You need to restrict more fluids as you are giving right now. So two scenarios, two extremes can be there. Both of them need to be identified and need to be corrected. So look at the answer question number 3 again. There is extensive weight loss more than 1% and there is increase in serum sodium concentration. It shows that you are not giving the bare minimum maintenance fluid to the child. So answer for this is inadequate daily fluid replacement. What should you do? Correct where you are lacking, where fluid is not being given, and you need to replenish that fluid, right? Question number 3, the answer is B. Question number 4, a lady delivered a baby with bilateral renal agenesis. The baby had features of Potter syndrome and died soon after birth due to pulmonary complication. You know that Potter syndrome children, they die due to pulmonary hypoplasia. What is the recurrence risk in subsequent pregnancies? See, it's a one-liner, but there are few things that you need to remember. Whenever there is bilateral renal agenesis, there will be absent urine production. Fetal urine is a major constituent of amniotic fluid, and because of bilateral renal agenesis, there will be severe oligohydramnios in utero. This severe oligohydramnios will cause fetal compression in the child. This fetal compression will result in multiple things. First of all, it will produce the typical Potter facies. Abnormal facies will be produced. What is Potter facies? Anti-mongoloid slant of eyes, increased gap between the two eyes, and sometimes epicanthic folds can be seen, receding of the chin can be there, low set ears can be there. That is called as Potter facies. So typically compressed kind of face, broadened nasal bridge or beaked nasal bridge has also been described. We call it as Potter facies. Secondly, you will find that there is lung or pulmonary hypoplasia in the child. And thirdly, you will find that these patients have, this is the cause of death in these patients. And thirdly, there will be limb defects or limb anomalies, majorly involving the lower limbs, but upper limbs can also be involved. This entire sequence or syndrome is called as Potter syndrome. Now, Potter syndrome has classically been described for bilateral renal agenesis, but it can also be seen in conditions like cystic dysplasias of the kidney. It can be seen in patients with ARPKD, and very rarely it can be seen in autosomal dominant polycystic kidney disease also. Last but not the least, obstructive uropathies, that is severe posterior urethral valve in utero, can also produce similar Potter syndrome-like presentation. So these are the other causes that you need to remember. And remember, overall chances of bilateral renal agenesis associated Potter syndrome is 5%. If one child has been found affected. So in subsequent pregnancies, the recurrence risk of bilateral renal agenesis with Potter syndrome is 5%. It is mentioned in all the standard books, not mentioned in Nelson. Similar question has been asked in AIMS super specialty exams many years back. So it's an old question, but a percentage which you need to remember. Potter syndrome, very, very important for your exam. Question number 5. Most important pathological condition affecting anion gap in children. So basically what we are talking about is metabolic acidosis. Metabolic acidosis can be associated with a normal anion gap and a high anion gap. So what is anion gap and what are the abnormalities related to it? This question is talking about. So metabolic acidosis, it's a condition in which the blood pH is less than 7.35 and the serum bicarbonate is less than 22 milliequivalents per liter. It is divided into high anion gap and normal anion gap variants. Causes of high anion gap, normal anion gap, you must have done. It is very frequently asked almost every alternate year. It used to be asked in NEET PG. It continues to be asked in NEET super specialty. People used to mark it wrong in NEET PG. People continue to mark it wrong in NEET super specialty exam. Don't worry, I'm not going to tell you about the causes. Causes you are supposed to remember. But what we are discussing here is related to anion gap. Now, anion gap formula is, anion gap, there is a formula which says that it is, we first of all add the positive ions, that is sodium plus potassium, and subtract chloride plus bicarbonate concentration from that, right? So positive ions minus negative ions, that gap which comes is called as anion gap. Very often you will find that in certain formulas potassium is being taken into consideration, other areas potassium is not being taken into consideration. And why does anion gap happens? Cause of anion gap is due to unmeasured anions in the body. It is majorly related to albumin. Albumin is the most important unmeasured ion. Sometimes it can also be due to phosphates, it can be due to sulfates, it can be due to lactates in the blood. So these are the reasons for why anion gap exists. Now, what is the normal anion gap value? Normal anion gap value in children is 8 to 16 milliequivalent per liter if potassium is considered, and it is 4 to 12 milliequivalent per liter if potassium is not considered. Now, what are the conditions which affect anion gap? It has been mentioned in multiple textbooks and also mentioned in AIMS PICO protocol that the most important condition affecting anion gap in children is hypoalbuminemia. You may have children with nephrotic syndrome, you may have children with renal disorders other than nephrotic syndrome, you may have malnutrition where there is hypoalbuminemia, and all of them will cause erroneous interpretation of anion gap. Hypoalbuminemia causes a reduction in the anion gap. Other causes which can affect anion gap, they include low magnesium, TPN with high acetate formulas, and citrate-based anticoagulant. So whenever you are doing calculation of metabolic acidosis with anion gap, always perform, if the serum albumin is low, if the serum albumin is less than 2.5 gram per deciliter, always perform a correction. What is the correction? For every 1 gram per deciliter fall in serum albumin, anion gap is to be increased by 2.5 to 3 milliequivalent per liter during calculations. This is very, very important that you need to remember. So go back to the question. Most important pathological condition which affects anion gap in children is hypoalbuminemia. That is your answer. Next we have question number 6. Which among the following is not correct regarding the workup of febrile seizure as per the latest AOCN 2021 guidelines? So in last year, December 2021, there have been a consensus statement or guidelines issued from Association of Child Neurology, and these guidelines pertain to febrile seizure in children, the definition, workup and management, and it has been modified, slightly modified compared to the older guidelines, and there have been subtle changes compared to the Western guidelines which are mentioned in Nelson. So compared to the ILAE drafts, compared to what is mentioned in CDT Pediatrics, compared to what is mentioned in Swyman and Nelson, there have been subtle recent changes, and a lot of evidence has also been taken into account while formulating this consensus statement. So for future upcoming super specialty exams, especially related to pediatrics, you can expect some questions to be asked from AOCN guidelines. Ideally, all of you should be reading AOCN update and compare it with Nelson, but a brief summary related question I wanted to discuss here, and so I have made this question here. Let us look at the 4 options. Let us first try to see the key findings, key things regarding workup which have been mentioned. I have taken only selective things, not everything, which I felt are important from exam point of view, and then we will come back to the options again. So, what are the key points from AOCN 2021 regarding febrile seizure in children? First of all, during workup, a complete blood count with inflammatory marker like CRP or procal is not needed in simple febrile seizure, but it is done in all complex febrile seizures and febrile status epilepticus, right? Regarding neuroimaging, CT or MRI is not needed in simple febrile seizure, especially the first episode of febrile seizure. For complex febrile seizure, the decision for CT or MRI needs to be individualized, right? So they have left a clinical area where the clinician, the pediatric neurologist, can himself or herself decide how to go and whether to go in or not. And the first episode of complex febrile seizure with focal findings, you need to do MRI brain within 72 hours. This is a very, very important new recommendation which was not a part of the original recommendation so far. Then EEG in febrile seizure is not needed in simple febrile seizure, but it is done in complex febrile seizure. Now, when to do EEG is again controversial. If you look at Nelson, it says that for 2 weeks you should not be doing EEG in febrile seizure. But the new guidelines say that EEG in febrile seizure, where it is indicated, particularly complex febrile seizure, it should be done in about a week's time. So there is some difference here as well. But again, it's a gray area, and gray areas where different guidelines conflict with each other, they are less likely to be asked in super specialty exam. So regarding EEG, it is where to be done, where not to be done, not needed in simple febrile seizure, needed in complex febrile seizure. Then lumbar puncture in febrile seizure. It is done in all children presenting with febrile status epilepticus irrespective of age. It is done in all febrile seizure children if there are features of meningitis irrespective of age, and it is not needed in all complex febrile seizure children. In addition, the guidelines also talk about where lumbar puncture can be considered, and there is a long lengthy list about it that you need to know. But these are the key points compared with the points which are mentioned in Nelson that I have mentioned at one place. Now, let us have a look at the question again and try to see. The question is asking not correct, right? So option number A, lumbar puncture is indicated in all children presenting with febrile status epilepticus. It is a true statement. EEG is not indicated in the first episode of simple febrile seizure. It is also a true statement. Lumbar puncture is not indicated in all complex febrile seizure patients. Option D is also correct. Look at option number C. Baseline blood count is needed in all patients of simple febrile seizure. Wrong. It is needed in complex and epilepticus patients, not in simple febrile seizure. And so this is the not correct statement. So this is a false statement. And so odd one out, answer to question number 6 is C. Question number 7. Immediate treatment of choice in a pediatric patient who develops acute atrial flutter and is also in severe CCF with low consciousness. So they are basically talking about management of atrial flutter in children. So let us discuss a few key points here. Atrial flutter is also called as intra-atrial re-entering tachycardia. So if instead of flutter, they mention this statement, this word, don't get confused. They are referring to atrial flutter only. What is the heart rate in atrial flutter? In case of newborns, it is 400 to 600 per minute is the atrial rate, and 250 to 300 per minute in older children and adolescents. Obviously, with such a high heart rate, there will be some degree of EV block happening, and so ventricle will be beating separately. The ventricular rate will be different from the atrial rate. It can precipitate congestive cardiac failure, and it can also cause thromboembolism. Also, you need to understand that atrial flutter can occur in a variety of states. In case of newborns, it can occur in normal heart also, particularly when myocarditis happens. Older children, it can happen with congenital heart diseases or surgeries like Fontan surgery, like Norwood procedure, etc. So different kinds of surgeries can precipitate flutter in the children. When you do ECG, it will show the classic appearance called as sawtooth waves. What is the diagnosis? What is the management? See, in case the patient is having, there is acute atrial flutter, and the patient is either unstable. Unstable patient will be where there is depressed consciousness or there is shock, etc. Or the patient is having severe congestive cardiac failure. According to IMS protocol as well as all the guidelines and Nelson, you need to do immediate synchronized cardioversion will be needed in these patients. In case the patient is relatively stable, or it is not an acute thing, already it had been occurring for some time, or there have been episodes previously, you will consider putting the patient on drugs. You can skip doing cardioversion. The drugs which can be used, they include IV propranolol, so beta blockers can be used. You can use IV procainamide, and sometimes IV amiodarone can also be used. The point to remember is if the patient is already on digoxin for a pre-existing heart disease, in these patients doing cardioversion is a decision which is tricky, which should be taken only if there is no other alternative available, because digoxin plus cardioversion is not a good thing to happen. Details are obviously there we have discussed in arrhythmias. And also you need to understand that in case the patient has been on digoxin, you need to continue digoxin after the patient has been stabilized on any of these drug therapies. Plus, all of these patients will also require anticoagulation. And anticoagulation needs to be started because the risk of thromboembolism will be present in these patients. Now go back to the question and see. You will find that the patient is having atrial flutter, severe CCF with low consciousness. What are you going to do? You are going to do immediate synchronized DC cardioversion. That is your answer of choice. Now coming to question number 8. Which among the following is an indication for non-invasive ventilation? Now the indications and contraindications which I am going to discuss here, they have been referenced from multiple sources, but majorly from Indian Academy of Pediatrics series related to pediatric critical care. One of the authors there is now, what are the indications and contraindications for non-invasive ventilation? The non-invasive ventilation means you are not using an invasive artificial airway. If ventilation is provided through endotracheal tube or tracheostomy, that is invasive ventilation. Anything other than that, ventilation being provided is non-invasive ventilation, NIV. So, what are the indications? These are the important indications based upon the IAP pediatric series for critical care. First is hypoxemic or type 1 respiratory failure without ARDS, because once ARDS develops, obviously you need to go in for ventilation of an invasive variety, which is more successful in these patients. So hypoxemic or type 1 respiratory failure. Then we have hypercapnic or type 2 respiratory failure. Different textbooks say that success rate in hypercapnic is more compared to the hypoxemic respiratory failure. Here you find that there is a 80% success rate in stabilizing the patient, whereas here you find that there is only a 65 to 70% success rate in type 1 respiratory failure. Then acute respiratory failure in immunocompromised children. Suppose you have an oncology patient and there is a risk of opportunistic infection. So in these patients, for any acute respiratory failure, which is not still in the realm of severe ARDS, you can go in for NIV. Then weaning from invasive ventilation, you can use NIV. Palliative care in do not intubate patients, you can use NIV. And obstructive sleep apnea is another indication where NIV can be used. Now the question rises, what are the contraindications? These are the contraindications. In case the patient is having a low GCS, weak gag or cough reflex, since NIV cannot protect the airway, there is a chance of aspiration and so you cannot use it. Vomiting and gastric bleeding, you cannot use it. Craniofacial trauma, again there are technical difficulties in giving NIV. Hemodynamic instability like severe shock, you cannot use it. Severe ARDS, the procedure, the therapy of choice is invasive ventilation. NIV by itself can be used in mild cases, but moderate to severe ARDS, always you require intubation and ventilation. And abundant secretions, if they are present, again NIV will not be effective. So these are considered to be the contraindications of NIV. Now let us have a look at the question. Which among the following is an indication for non-invasive ventilation? So if you look at these options, this is a contraindication, this is a contraindication, this is a contraindication. This is an indication. Hypoxemic respiratory failure without ARDS, right? Question number 9. Most common cause of pneumonia in children with cystic fibrosis. Easy question, but still people get it wrong. If they say overall or adult, the answer will be Pseudomonas. Which strain? Mucoid strain, more common than non-mucoid strain. But if they say children, the answer will be Staph aureus. If you look at the various graphs, various data given in various review articles as well as Nelson, you will find that look at this graph of Staph aureus. This green colored graph is the Staph aureus one. Can you see that it is the most, in the age group of from 0 to 17, this is the most common bacteria causing pneumonia. Then around 17 or 18 years of age, you will find that Staph aureus becomes second most common and Pseudomonas aeruginosa becomes the most common. So when they say childhood, in children, Staph aureus will continue to be the most likely answer. So answer to the question number 9 is A, Staph aureus, easy one. Question number 10. All of the following are causes of false positive sweat chloride test. Sweat chloride test is a screening test for cystic fibrosis except newborns, where it is a neonatal trypsinogen assay. Sweat chloride levels, if they are more than 60 millicuries per liter, we consider it to be a positive sweat chloride test. The problem is there are false positive and false negative tests. So what are the causes? Let us discuss. False positive sweat chloride test. False positive means the sweat chloride is more than 60, but the patient is not having cystic fibrosis, right? So this can be seen in atopic dermatitis. It can happen in anorexia nervosa. Why is the difference between the colors? The one which I have highlighted are the important ones which have been asked directly, indirectly in the past papers. So atopic dermatitis or eczema, anorexia nervosa, autonomic dysfunction, adrenal insufficiency, congenital adrenal hyperplasia, ectodermal dysplasias, fucosidosis, familial hypoparathyroidism, familial cholestasis syndrome, glycogen storage disease type 1, that is Van Gerke disease, hypothyroidism. So both hypothyroidism and hypoparathyroidism can cause a false positive test. Klinefelter syndrome, Mauriac syndrome, Munchausen syndrome by proxy, nephrogenic DI, prostaglandin E1, that is alprostadil infusion, pseudo-hypoaldosteronism, protein energy malnutrition. These are the causes of false positive sweat chloride test. Now, what are the causes of false negative sweat chloride test? False negative means the patient has cystic fibrosis, but sweat chloride level will not be more than 60 millicurie per liter, right? So this will include dilution. Another cause is PEM. So PEM can cause both false positive and false negative sweat chloride test. Can be a potential MCQ again. Edema, hyponatremia, very, very important. Hyponatremia. And then you have insufficient sweat quantity and then CFTR mutations with preserved sweat duct function. This can be additional MCQ. What are the CFTR mutations where there is a preserved sweat duct function? One is 3849 plus 10 kb C to T conversion, and second is arginine 117 histidine 70 mutation. So these are the two mutations that you need to remember can cause a false negative sweat chloride test. So let us look at the question again. All of the following causes of false positive sweat chloride test except CAH can cause false positive test, nephrogenic DI can cause, hypothyroidism can cause. Hyponatremia is the one which is left out. It causes a false negative sweat chloride test, not a false positive, and so the answer to this question is C, hyponatremia. Questions. What I have taken here, you need to understand the concepts behind them, and whatever additional points you find, please add them to your notes. Keep practicing MCQs. Only theory, but only MCQs are not going to work alone. Bring them in synergy. You have a much better chance of getting a top rank. Thank you. Thank you very much.